Hello, everybody. My name is Dr. Elmufti. I'm a pediatric endocrinologist in the Carilion clinic. I'll be talking today about thyroid disease in children. First, I have no financial disclosure or conflicts of interest in relation to this presentation. Those are the objectives of my talk. I'll be talking about normal thyroid development, normal thyroid function, congenital hypothyroidism, Hashimoto Thyroiditis, Graves' disease, Thyroglossal duct cyst. And each one of those categories is a separate talk. But I'll try to talk about each one of them and mention as much information as I can with the time limits. Okay. So we'll start with thyroid development. So the thyroid gland arises from at the base of the tongue, migrates towards anterior neck by 5 to 6 weeks gestation. Usually the fetal thyroid function does not depend on maternal system. Some maternal thyroid hormone cross the placenta, and there's usually placental passage of T4 by the first trimester. The newborn thyroid usually we see high TSH surges, in the first 1 or 2 days after birth. The rise in TSH stimulates secretion of T4, and that's important because some or most of the newborn screens use TSH without T4, so it's important to know that TSH is usually elevated in the first 1 or 2 days, and then it kind of comes down. Premature babies have lower normal values than term babies, so that's also important to know for NICU people. With thyroid hormones, we have thyrotropin releasing hormone, TRH, thyroid stimulating hormone, TSH, thyroxine, T4, and more accurate is the free T4, which is the unbound T4, and then T3. We're going to be talking more about that. Thyroid hormone function. Thyroid hormone is very important and critical for growth and brain development. Along with that come other functions, including cell metabolism, bone maturation, and puberty. We're going to be talking about each one of those. Growth, T4 is needed for synthesis of growth hormone, and it also works with growth hormone to promote bone growth. T4 actually is not critical for fetal growth. Insulin and IGF-1 are the main growth factors for fetal growth. Brain development, and that's important, and I will be talking about that again at some point during this presentation. T4 is needed for brain cell maturation, and motor development is dependent on T4. Normal thyroid levels are important for brain development from birth until 3 years old, and that's important here to know that number, the 3 years old, and I will say why. Brain function as reflected in school performance can be affected if hypothyroidism persists. Adequate thyroxine replacement, normal school performance. Thyroid hormone is important, very important for brain development, especially from birth until the first 3 years. Cell metabolism is increased by T4. Bone maturation. T4 is important for prenatal skeletal development, beginning at 6 to 8 weeks before birth. Babies with congenital hypothyroidism may be born with bone age delay because T4 is important for skeletal development. Puberty, hypothyroidism is one of the differential diagnoses and the possibilities for children presenting with delayed onset puberty. So it's always something to check for thyroid function when kids present with delayed puberty or like primary amenorrhea. Next, I'll be talking about the thyroid hormone function. So we're going to talk here about the feedback mechanism for thyroid hormone. And as I mentioned earlier, we're going to be talking about the TRH, TSH, and then the T4 and the T3. Okay, so we have the brain, the hypothalamus that sends the signal, which is the TRH. goes to the pituitary gland. Pituitary gland sends a signal, which is the TSH, to the thyroid gland, and then the thyroid gland secretes the thyroid hormone. If your problem is primary thyroid problem, the problem is on the thyroid gland itself. Whatever, if it's an autoimmune problem or any cause of damage to the thyroid gland or surgical, there will be less production of T4 and T3. There will be less negative feedback on the brain, and then you'll see that the TRH and the TSH will go up. So usually the first feature of hypothyroidism will be elevated TSH, because the pituitary will be trying to compensate for the non-functioning thyroid gland, and then you will see always a high TSH. And we call that the thyroid thermostat. Here we have, this is what the normal thyroid is, pituitary, thyroid gland, TSH, and then T3, and that's the feedback mechanism I was just talking about. For hypothyroidism, as I mentioned, you will see less T3 and more TSH. On hyperthyroidism, it will be the opposite, because there will be more T3, and that will cause a negative feedback, and then the TSH will be low. Okay? And it's just important to know that whole feedback mechanism. Like on hypothyroidism, you'll see high TSHs. In hyperthyroidism, you'll see suppressed TSH. Talking a little bit about thyroid function tests, and that's a very common thing that we get for all primary care providers, and how you can evaluate them. TSH, thyroid stimulating hormone, is the most sensitive test of thyroid function in primary thyroid disease. And it's important to mention here it's primary thyroid disease, because when we're talking about central or secondary thyroid disease, the free T4 will be the most sensitive test. Okay? TSH, free T4, measures the free portion of T4, 5% of total. We always prefer TSH and free T4 as thyroid function test more than total T4, because free T4 is more like the free portion of T4, and it's more sensitive. As I mentioned just a few seconds ago, the best test for kids is free T4 and TSH. And for central hypothyroidism, free T4 comes before TSH. In primary thyroid disease, TSH comes before the free T4. Total T4, a lot of newborn screen programs nationwide use the total T4, but as I mentioned, free T4 is more sensitive. Why? Because there's some babies with conditions like thyroid binding globulin deficiency or thyroid binding globulin excess, and those could cause, the excess will cause like falsely elevated T4, and TPG deficiency will cause like falsely low T4. So the summary of this slide is use mostly TSH and free T4 to test the thyroid function. Next will be congenital hypothyroidism. It's 1 in 4,000 births, less frequent in African American, more frequent in Hispanic, more common in Down syndrome patient. And Down syndrome patients have high risk for thyroid disease, including congenital hypothyroidism and autoimmune thyroid disease. So that's disease population that we always should screen them at least annually for thyroid problem because of their high risk. This is the leading cause of preventable mental retardation, and I mean, fortunately, and it's good that we have the newborn screen, so we usually catch them early before any irreversible changes happen. On third world countries or developing countries, who don't have the newborn screen, a lot of time they will catch congenital hypothyroidism late, and a lot of those changes will be irreversible, even if you started the thyroid medication at that time. It's the most common congenital endocrine disorder, and there's different reasons for congenital hypothyroidism, dysgenesis being the most common. I'll come and talk about the others. So permanent hypothyroidism, thyroid dysgenesis, 85%, and that just means absence of the thyroid gland. Thyroid dyshormonogenesis, and that's problem in the hormone synthesis, and then hypothalamic hypothyroidism, and that's the least common. Transient hypothyroidism, we'll come and talk about that more, but it's also one of the things that we see a lot on babies, and it's always kind of difficult way to decide. Should we start thyroid medication? Should we wait? So we can always talk more about that. Thyroid dysgenesis is thyroid aplasia, hypoplasia, or ectopic thyroid. Ectopic thyroid, most common is like lingual, so it's very important to do when you do the exam, like to check the mouth to check if there's any lingual thyroid, and that's one part which is important when you see any kid with congenital hypothyroidism. And then comes next is mutations, and those are rare. This is a picture of a lingual thyroid. If you just open the mouth, you just see the thyroid sitting there, and that's always good to know. It's not going to change the management, but it's good to know what's causing the congenital hypothyroidism. Dyshormonogenesis, thyroid peroxidase deficiency is the most common. There's a lot of other mutations: thyroglobulin deficiency, TSH receptor abnormality, pendrin, and that you see that on Pendred syndrome, and MCT8 transporter, and that's also kind of common, and we see that too. Transient congenital hypothyroidism, and that usually happens because of maternal blocking antibodies or excessive iodine exposure. If a mom is on propylthyrosol or any antithyroid therapy, it takes it a while to clear, 3 to 4 days. So that's something to pay attention to. Iodine deficiency and then heterozygous mutations. Those all could cause transient congenital hypothyroidism. The clinical picture of congenital hypothyroidism, as I mentioned earlier, luckily because we have the newborn screen here, a lot of times we see kids and they will not have any abnormalities on physical exam. Few things that you can see is one of them is the goiter, and that could happen even prenatally, and or sometimes develop postnatally. But most signs and symptoms of congenital hypothyroidism could happen later on, usually after the first month that we really see them. Those are the features of congenital hypothyroidism. As I mentioned, third world countries or developing countries, or somebody who's immigrating from another country, that's important to know, but on kids who are here, most of the time, when you get the newborn screen, you will catch them before you see any of those signs, But one important thing is large posterior fontanelle, prolonged jaundice, and that's important for NICU people that they always test for thyroid if you see a kid with prolonged jaundice, mostly unconjugated, or indirect hyperbilirubinemia. Large tongue, hoarse cry, distended abdomen, low tone, umbilical hernia, and goiter, as I mentioned. And as I mentioned, usually normal exam. Less than 5% of patients are diagnosed on physical exam. 15 to 20% will have suggestive signs at 4 to 6 weeks. And that's important to know. 4 to 6 weeks is usually the age that we have to decide at that point if we're going to start thyroid medication or not. A lot of articles and updates talking about 6 weeks and later, you will start seeing signs of congenital hypothyroidism, that some of them will be irreversible. So it's always important to figure out if you want to start medication before that time period. Evaluation, again, as I mentioned, we send for free T4 and TSH. Total T4 can help to diagnose TPG deficiency. Sometime we do imaging studies, including thyroid scan or thyroid ultrasound. As I mentioned, that most likely will not change the management, but it's still good to know if the cause of the congenital hypothyroidism is ectopic thyroid. That will be, and it's good to know if there is any thyroid tissue when you do the thyroid scan. So that would really be helpful. Bone age, that's just a picture of a delayed bone age in neonate. And as I mentioned earlier, thyroid hormone is important for bone maturation. So in babies, you can see skeletal bone age delay in babies with congenital hypothyroidism. So I myself, most of the time, do one of those imaging studies just to know the etiology of the hypothyroidism. But as I mentioned, it will not change the management. Medication, it's important to start as soon as possible, even in the first 2 weeks. But as I mentioned, 4 to 6 weeks will be the last kind of deadline for starting Synthroid or thyroid hormone replacement. And the dose is usually 10 to 15 micrograms per kg per day. It's usually tablets. There is no suspension available. You have to mix it with a small volume of water or breast milk, and then give it to the baby. You should avoid giving it with soy or iron or calcium or high fiber diets, because that could interfere with the absorption of the thyroid hormone. So this slide is important, showing that at least by the age of 2 to 3 weeks, we will have to start the thyroid medication to avoid irreversible issues that could be associated with congenital hypothyroidism. And a lot of times, like if any question, you can always contact us or send us the patient. And if you're leaning more towards starting treatment, we can always do that, even for transient congenital hypothyroidism, so as to preserve the thyroid hormone. And a lot of times we do start them, and then when they're like 3 years, as I mentioned earlier, that brain maturation is almost done, we can always do what we call like a trial off, like try them off the thyroid hormone and see how they do. But usually within that critical time, up to age of 3 years, if you're leaning towards starting thyroid hormone, we should always start it to avoid issues. Next will be autoimmune thyroiditis, and that's a spectrum of disease, goes from hypothyroidism to hyperthyroidism. And the two important antibodies here are thyroglobulin antibody and thyroid peroxidase antibody titers. But as I mentioned, it's a spectrum. A lot of people will think about it as just hypothyroidism or hyperthyroidism, but autoimmune thyroiditis is a spectrum, so it could go both ways, and I'll talk more about that. On the side of the hyperthyroidism, you'll see more thyroid-stimulating immunoglobulin, and that's a positive antibody that helps to differentiate Graves' disease from other causes of hyperthyroidism. And sometimes we still see it on Hashimoto's, but it's very uncommon to see TSI positive in Hashimoto thyroiditis. It's more common with Graves' disease. This is Hashimoto's, who the first one to discover Hashimoto thyroiditis. That's the most, Hashimoto thyroiditis, the most common cause of goiter in patients more than 6 years. So sending for thyroid peroxidase antibody and thyroglobulin antibody will be first an initial point for patients presenting with goiter. Usually it's like a multilobular thyroid due to lymphocytic infiltration of the thyroid, and that's the pathophysiology of Hashimoto thyroiditis. And obviously the other name for it is chronic lymphocytic thyroiditis because of the lymphocytic infiltration of the thyroid. There is increased frequency in some conditions like Down syndrome, Turner syndrome, and Klinefelter syndrome. Those patient population have high risk for Hashimoto thyroiditis, so it's something always to check for. Those are signs and symptoms of hypothyroidism. In general, for us in pediatrics, it's important to know that thyroid is really important for growth and brain development, and it's very, very critical to normalize the thyroid status for children, because they need the thyroid hormone for growth, they need it for brain maturation, they need it for puberty. So that's always important to know. In addition to that, thyroid hormone affect almost every system on the body. So in general, we see kids who will be complaining of tiredness, fatigue, cold intolerance, weight gain, hair loss. In the lungs, if you see severe hypothyroidism, they could present with breathing problems and pleural effusion. Severe hypothyroidism on the skin can present with edema, like mixed edema. And that's not very common, but we did see that in cases of severe hypothyroidism. Constipation, as we all know, and then irregular menstrual cycle. It could go both ways, amenorrhea or menorrhagia, but we see more of the menorrhagia with the hypothyroidism and more of the amenorrhea with the hyperthyroidism. But still, as I mentioned, it could go both ways. Poor memory and concentration. A lot of kids, will have memory and concentration problems at school, and the whole problem would be just like hypothyroidism. Poor hearing. Thyroid is important for hearing. Hoarseness of voice. Obviously, bradycardia or slow pulse rate, and delayed reflex or relaxation, carpal tunnel syndrome, and that's more in adult population. But it's important just to see how much the thyroid hormone affects and how many systems on the body are affected by the thyroid hormone. The labs as I mentioned earlier, that we need to send for Hashimoto thyroiditis or autoimmune thyroiditis is thyroid peroxidase antibody and thyroglobulin antibody. Hashimoto's thyroiditis on itself, it could present in 4 different ways. The most that we see is hypothyroidism, but still it could present in 3 other ways of presentation. Hypothyroidism is the most common, low free T4, high TSH, and then you find positive thyroid antibodies, and then that's just hypothyroidism. But most of the time, it will usually start with hyperthyroidism, which we call like hashitoxicosis. And that would be like a very short and transient period that you will see high free T4 and low TSH, maybe a few weeks, and then it will transition to the euthyroid, which will be the normal free T4 and normal TSH, and then eventually it will be like permanent hypothyroidism. Okay, so a lot of times hyperthyroidism is not only Graves' disease. There's multiple reasons for hyperthyroidism. One of them is hashitoxicosis, but a lot of times, because the free T4 is not elevated that much, we don't see kids presenting with symptoms, and they usually just transition to the hypothyroidism before we really see them. So that's just important to know that Hashimoto's thyroiditis have different phases, starting with hashitoxicosis, which is hyperthyroidism, and then euthyroid, and then hypothyroid. Okay, I mean, before the hypothyroid, you can see compensated hypothyroidism, which just means that free T4 is normal and the TSH is high. Treatment, the same as congenital hypothyroidism, with a little bit difference on the dosing. We use thyroid hormone replacement and levothyroxine. So the dose of the synthroid is like 50 to 100 microgram per meter square per day, and we base the dose here on meter square more than the weight. Usually, because the thyroid hormone half-life is long, usually we wait 5 to 6 weeks before we get repeat lapse of thyroid hormone to see if we need to adjust the medications more. Okay, there is some articles and updates that talks about treating euthyroid patients, meaning patients who have normal thyroid function but positive thyroid antibodies. And there's a lot of talk if that will really help to decrease the size of goiter. Most of the updates say that it's not successful, but I mean some more, especially in the adult population, some endocrinologists will use levothyroxine just for treating the goiter, even with normal thyroid function. Okay, here in this picture, it's just important to note that the examination of the thyroid gland should be from behind, not from the front. And this is really, really important on the way that you use 2 fingers here, as mentioned in the picture, to examine the thyroid gland, and you should be behind. The examiner should always be behind the patient. This is a picture of a growth percentile for a kid who had problem with growing, and then if you see here the way that growth deceleration is, so thyroid hormone is one important thing that we check for all kids that we see for growth problems, either short stature or growth deceleration. And you see here, this is where they started the thyroid hormone, and the growth picked up, eventually kind of got on the chart. But it's very, very important to check for it, and it's a very simple test to do, and it's easy to fix, if that's the cause of the growth delay or the growth deceleration. Next will be Graves' disease, and that's the other end of the spectrum, which is the hyperthyroidism, and that's the most common cause of thyrotoxicosis in pediatrics. Okay, antibodies, as I mentioned earlier, TSI, thyroid-stimulated immunoglobulin, is the most common antibody on Graves' disease. TB, that's another antibody. Usually we send for both of those because it will just help us to guide us on treatment. It's just good to know because, as I mentioned, there's a lot of different causes for hyperthyroidism. Unlike hashitoxicosis, you can always wait and observe and do not start like antithyroid medication if that's the story. But if you know that it's positive TSI and it's Graves' disease, then the next step will be to start the antithyroid medication. Along with beta blockers and other medications. We come and talk about that. You can also see positive thyroid peroxidase antibody and thyroglobulin antibody. As I mentioned, those antibodies, even though they're more common on Hashimoto thyroiditis, but still, because it's a spectrum, you can see all those 3 antibodies in Graves' disease. And the lab that you will see in Graves' disease, initially, first thing will happen that the TSH will be suppressed. And then elevated free T4 and total T3. On on hyperthyroidism, in hypothyroidism, we said the best test will be free T4 and TSH. On hyperthyroidism, the best test will be TSH, free T4, and total T3. It's really helpful here in hyperthyroidism on the initial diagnosis and then on the future for follow-up. So that's a point to note too. Not free T3, total T3. This is also shows the signs and symptoms of hyperthyroidism. And as I mentioned, it does affect most of the symptoms, and most of those are just the opposite for the hypothyroidism. So intolerance to heat, fine straight hair, bulging eyes, exophthalmos, or proptosis is a very common thing that we see with hyperthyroidism. And a lot of times they'll be seen by the eye doctor who is sent for thyroid labs, and then they'll be referred to us. So that's something to think about. When you see proptosis or exophthalmos, this is one of the common features that we see with Graves' disease or Graves' ophthalmopathy. Okay? Enlarged thyroid, as I mentioned, tachycardia and wide pulse pressure, increased systolic blood pressure, gynecomastia or breast enlargement, weight loss, muscle wasting, edema. Edema could happen with hyper and hypothyroidism. Poor attention, difficulty sleeping, hyperactivity. The mom would just tell you that the kid is all over the place. He's not sleeping. He's not going to bed. It takes him time to sleep. So that's one thing to always think about. Clubbing of the fingers, that you will see it in really chronic hyperthyroidism, which is uncontrolled. Tremors, that's one thing that you can always examine for. The shaking and the tremors, they have to spread their fingers, and you will see the shaking. It will be very clear. Diarrhea, and then menstrual changes. As I mentioned earlier, on hyperthyroidism, it's more amenorrhea than menorrhagia, but still we see menorrhagia with hyperthyroidism, and we see amenorrhea with hypothyroidism. You have to distinguish Graves' hyperthyroidism from hashimotoxicosis, like I mentioned. Treatment options, there is 3 options. Antithyroid drugs, and we mostly use on pediatrics methimazole, surgery, which is total thyroidectomy, and then radioablation therapy. There is high chance of resolution in kids who are 2 years. Like usually, like in the first 2 years when you start treatment. Medications, the first line of therapy in pediatrics, is antithyroid medication. Adults go more for radioactive ablation and surgery, but for us, we usually start with antithyroid medication. And the famous one is methimazole or tapazole, and that inhibits thyroid hormone production. PTU, which is propylthyrosol, is no longer recommended because of the risk of liver failure. Usually when they present initially because of the tachycardia and the hypertension, we usually start them in beta blockers until we get the thyroid function under control, and then we can stop the beta blockers. Possibility of remission, 60 to 70% with drug therapy, and a lot of times with the decrease on the size of the thyroid, you will see drop on the antibodies. So sometimes we use thyroid-stimulating immunoglobulin or thyroid antibodies to see the response for the thyroid medication and the risk for relapse too. With the thyroid medication, a lot of times even if you got the thyroid under control, there is still some risk of relapse, and it's actually high risk, that we always see it a lot of times, and it's more likely to happen in younger patients than older patients. So the summary for that slide, methimazole is a treatment that we use, and we as endocrinologists, most of the time, we do handle all the cases of hyperthyroidism. So that's a case that you can always refer to us, but that's the first modality of treatment or the first line of therapy. Side effects of methimazole, allergic reaction as any other medication, that would be the most common one. But the most serious one and the most significant one is bone marrow suppression. Okay, so it's very, very important to send for CBC before starting the treatment, because Graves' disease itself could cause leukopenia and neutropenia just on itself without the medication. So it's always good to know before you start the medication that if they have that, because usually when you get them after the medication, you need to differentiate if that's the Graves' disease that is causing that or that is the medication that is causing that. So Okay. So so we need just to get CBC and liver function test before we start the treatment. So just kind of go a little bit quicker because of the time limits. Other modalities is radioactive iodine therapy and thyroidectomy. And we usually use those as second line or third line after we use the thyroid medication. This is just a summary of if you see a kid with goiter for hypothyroidism, for like 3T4 TSH and then the thyroid peroxidase antibody and the TSI, which one should you usually consider imaging or not? Like most of them, like hyper, and euthyroid, you do not do imaging. But you always have to send for thyroid antibodies, and that will really help you on differentiating things. Last is the thyroglossal duct cyst. That's usually centrally located above the thyroid, and it moves with swallowing. So that's a point that you always should look on. You should ask them to swallow, and you see that it moves with swallowing. Most of the time, asymptomatic. Treatment could be observation, no need for thyroid function test, but you can order a thyroid scan prior to surgery to assess the presence of any thyroid tissue on the cyst before you remove it. So that's important to do before you do the surgery. Most of the time asymptomatic, but could present with recurrent infections. Okay.